This is Pediatric Lecture 3, Part 3, and we're going to talk about fractures. So, fractures are common in children but rare in infants, and the exception to that is motor vehicle crashes. Clavicle is the most common bone that's broken in childhood. Often bicycles and sports injuries, and we do treat them different in the pediatric population than in adults because we get different types of fractures, right? In adults, you get this complete break, or with, that's just a little periosteum stuck on there. But kids, because their bones are still pretty soft, you get this green stick. And then as that comes back and heals, it makes this funny thing here, this buckle, or it stays deformed. So that's because their bones are softer. It's just like a soft green stick compared to a really brittle stick that snaps. And our biggest issue is the growth plate, the epiphyseal growth plate. So this is the weakest part of the bone, and when it breaks there, it can do damage to growth. So it is a frequent site of trauma and can affect future growth. So we often do surgery. Open means surgical. Reduction is putting it back together. And internal fixation is using pins and things because we get less disturbance of the growth by doing it that way. And so here's our growth plate. It kind of goes along there. So we can have different cracks through it, just partially through it, just kind of an angle through it, or this, I think there's just damage to it there. So bone healing is a lot faster in kids. Neonates 2 to 3 weeks, early childhood 4 weeks, later childhood 6 to 8. Adolescents now are getting up closer to what adults take, right? 8 to 12 weeks. So we do casting with kids, even though I said we often have to do surgery. So long, short leg cast, we can put a bar between them. Anything where we're going over the hips is called a spica cast. And you got to think about this: the kid can't fit in a normal car seat. We've got to get a lying car seat. If they're little, we'll have the parents use a wagon to pull them around, but if they're any bigger than that, we got to get a wheelchair that's got a reclining back because they can't bend at the hip. And here's another spica cast just on a single leg, and then shorter long arm casts. Moving on, developmental dysplasia of the hip. We used to call it congenital dislocated hip, but not all of them are fully dislocated, so that's why we've kind of changed the name. This is what we should have, the ball in the socket really well. In utero, if it's not quite in place, it doesn't develop quite right. See how it should be all the way curved around here, and it's not. And the farther out it is, the more problem you have until you have it fully dislocated and out, and it just really doesn't develop correctly. So signs, we're going to look, the skin folds are not the same. The leg length is not the same. The skin folds are not the same. And you may have heard of this, of listening for a hip click. You put the hips through their range of motion, and you're hearing it click in and out of the joint. And if you really do end up with that, you end up with one hip out of joint, so you stand funny. The earlier we can treat this, the better. So, newborn to 6 months of age, we just put them in a harness that keeps that hip where it should be. There's still a lot of growth that's going to happen to those bones. If the hip is correctly aligned, those bones will grow. So as long as we catch it before 6 months, all they need is a harness, and they will end up with usually a perfect fix. No limp, nothing. If we don't catch it before 6 months, if we're talking more like 6 to 24 months, we're probably going to have to do casting to hold it in place. So it's harder for the child to deal with than the harness, and they probably will have a limp. If they're older than a couple years old, we're going to need to do surgery to try and get that hip aligned correctly, and it probably will never be a very perfect repair. So the earlier, the easier, and the better. And this is what the harness looks like. It just holds those legs adducted, but a little bit anterior too. Club foot. This is the foot is bent in when they're born. So what we can do is serial casting. We push it as far as possible and put a cast on. A week later, take that off, push it as much more as we can, put a cast on. So that serial casting, if it's mild, is enough to correct it. Sometimes they need surgery, and often this goes along with other issues that they might have. So here's a baby with the casts on. Osteogenic, let me just say, kids with casts, they get used to them really quickly, and they do just fine with them. And in fact, sometimes they're frightened when you take it off because they get used to having it. So osteogenesis imperfecta, this is often called brittle bone disease. So it's a group of inherited disorders characterized by fragile bones. Going along with it, usually they have kind of blue sclera of the eyes and abnormal teeth. There are a few different types of this that can range from mild to extremely severe. Most of them are the mild type. Spinal curves, right? So we've got kyphosis, upper back, lordosis, that's way back, and then scoliosis, which is a twisting. So with scoliosis, it can be lumbar or thoracic, and this is, we have the child bend down and we see their back is not flat. They've got that hump. So here's a kid with scoliosis, and this is what we do. We go, it's a big surgery, put in rods to straighten that back. And here's actually somebody who put their pictures online of what they had before, and you can see here the hump they have when they bend down and how much straighter she was. So here's her surgery, pre-surgery and post-surgery x-rays. Let's talk about a few neurosensory disorders: cerebral palsy, spina bifida, Down syndrome, and muscular dystrophy. So CP, this is not progressive, so it doesn't get worse, but it's a disorder of movement and posture and balance. We used to think these all happened from hypoxia at birth, but they're saying most cases actually occur before birth in utero, but it can be before, during, or after birth. And they have abnormal movement. These kids, it's motor nerves in the brain that have a problem. Cognitive may or may not. They can have normal cognition, but difficulty with moving. These kids spend so much extra energy because it's so hard for them to move. So we do need to make sure they get rest periods and figure out ways to help them be mobile. They want to be normal kids. Spina bifida, this is a neurotube defect. So we have incomplete closure of the vertebrae. This happens 3 to 4 weeks of development, which is 5 to 6 weeks of gestation, because remember, we go from the last period, the first day of the last period. We found that this folic acid deficiency makes more of these happen, so they recommend that every woman of childbearing age be taking a folic acid supplement, because this is occurring usually about the time a woman's starting to wonder if she's pregnant. So by the time she knows she's pregnant, it may be too late. It may have already developed. So there are 3 types. This is the back here and the spinal cord and the vertebrae, right? So this is just a dimple in the spine. So that's a spina bifida occulta. We can have a bubble of the meninges. So the covering, the membranous covering over the spinal cord pinches out between 2 of the vertebrae. Or we can have the whole spinal cord, the spinal nerves go out there as well. And here's a picture of one, and you can see how delicate that is. Our goal is to not break that. That's full of cerebral spinal fluid. If that breaks, we have germs going right into the spinal fluid, which turns into meningitis. So most babies who have spina bifida also have hydrocephalus, which is too much spinal fluid up here in the center of the brain, the ventricles of the brain. That's where your spinal fluid is made, and it's kind of a chicken and an egg. Did this cause pressure that made this go out, or was this a problem that pushed pressure up there? We don't know, but it usually goes together. So with spina bifida, before it's surgically repaired, and it will be within the first few days of life, but before it is, don't break that meningocele, which means don't put a diaper on that might rub on it. Don't position them supine on it. We're going to keep them prone, but we do want to treat them like a baby. So touch them, talk to them, give them a pacifier. We can feed them by a bottle. We're just going to feed them prone, kind of lift their bed up a little bit, turn their head to the side, and feed them that way. Some of the problems that go with this, the meningeal, myelomeningocele, when you have the spinal cord out there, is all the nerves get damaged. So these are typically the nerves to the bladder, the bowel, and the lower extremities. So they don't really have the ability to bear down and void. This is elective, but a lot of, particularly girls, choose to do this. So they have to do in and out catheters every day, several times every day. They make a little opening right through the umbilicus so they can easily do their catheter. And we do the same thing. They also have problems with constipation because, again, they can't bear down, they can't really feel it. So this is a chate, and it's an antegrade enema because they put it here and it flows down, and they get in a pattern just like the rest of us do, that, you know, every day or every other day they put in their enema fluid, and within 30 minutes they have a bowel movement. This is the same sort of thing. It's called a Malone. The difference is they use the appendix and bring it up to the surface instead of having that little plastic piece on there. And here's a little kid with Down syndrome. Down syndrome babies, they have some characteristic things. They're floppy, so decreased tone. We call it hypotonia. Excess skin around the nape of the neck, kind of the back of the neck, flat bridge of the nose, small upward slanted eyes. They have a small mouth and a large tongue, so they tend to be mouth breathers, which, if you remember, is really unusual. Babies are usually obligate nose breathers for at least 6 months. They have short, wide fingers with a single crease across the center of the palm, and wide first toe there, and the creases are not normal, or they don't even have a lot of creases on their feet. So this is caused by an extra chromosome in chromosome 21, so trisomy 21. Some of the other things, these kids often have a cardiac defect. They're more prone to infections, especially ear infections and respiratory infections. Most of them have vision and or hearing problems. And then just some sad things. They have a higher risk for developing childhood cancer like leukemia. Many of them are obese. And I've just been hearing recently they also have an increased risk for type 1 diabetes. Deschenes muscular dystrophy. This is something that the mom is the carrier and passes it on to half of her sons, and passes on that defective gene to half of her daughters, who will be carriers. Because that girl has a normal X from her dad, she becomes a carrier, but the sons will have the disorder. And this is a really sad disorder. Progressive degeneration. Life expectancy is about 25 years, and that's an improvement. The proteins in the muscle waste away and are replaced with fat, and so they lose muscle ability. Symptoms usually begin about 3 to 5. As I said, almost all boys, they have this typical way of having to kind of walk themselves up or standing, and you see this kind of sway back, and like I said, most die in the early to mid 20s.